program going, and then we usually have participants that come on in the next minute or two. But I'll let Matthew take it away. He's really good at this.
Thank you, Dr. Gordon. You're too kind. Thank you, everyone, for joining us today on Tuesday, January 20th, 2021. We're grateful for your attendance and your participation in this MAT VA webinar. Allison, would you please forward the slide? Just really quick, the mission of MAT VA is to improve health outcomes in veterans with substance use disorders through the use of medications in combination with non-pharmacological treatment approaches in a wide variety of outpatient and inpatient clinical environments. And one of the ways that we do that is through twice a month webinar sessions or journal clubs. Next slide, please. Just a quick breakdown of what we offer. We offer 2 webinars a month on the second and third Wednesday. This is supposed to be the third and fourth Wednesdays of the month. And also on the second Wednesday of the month, we do have a dedicated call towards scout processes, which are accredited, and you can receive credit through TMS. All presentations are recorded and archived on the MAT VA SharePoint. The tiny URL is located below, and I will also post it in the chat. You simply have to be on the VA network, and it is very easy to access. Next slide, please. A quick breakdown of the upcoming talks. Today, we're very pleased to hear from Dr. Varley and Dr. Kertesz. On January 27th, though, we will also be hearing from Drs. Untitled and Mudra. And also, we have further presentations planned for February 17th and the 24th. The topics are listed below for your perusal. Next slide, please. And once again, we do have a few more openings for the 2021 Journal Club season. If you know anyone or are interested in presenting an article or are an author of an article, we would love to hear from you. We're looking for a wide variety of substance use disorder topics, things like alcohol use disorder, opioid use disorder, tobacco, and furthermore in-depth topics like addiction in older populations, addiction in pain, and emerging trends. Next slide, please. Next slide, please. Just a few disclosures and acknowledgements. Dr. Kertesz espoused privately owned stock in Merrick, Johnson & Johnson, and Abbott. Dr. Kertesz attests to past ownership of CVS Caremark stock sold in 2020 and royalty income from UpToDate Inc. Dr. Varley has private employment outside the VA with Heart Rhythm Clinical and Research Solutions, LLC. The views expressed in this presentation are solely those of the presenters and do not necessarily reflect the position or policy of the Department of Veterans Affairs or the United States government or any other university or organization. The MAT VA presentations are sponsored by the VA Centers of Excellence in Substance Abuse Treatment and Education, or CSTATES, and the Salt Lake City VA Healthcare System. Next slide, please. And before I take a moment to introduce our wonderful speakers today, we encourage all of our participants, if they feel so inclined, to leave a question or comment in the chat box. There will be time at the end of this presentation, about 15 minutes, where I will be happy to read these questions off to the presenters and have a moderation session. We will probably not open the lines today due to the high volume of participants, but you are more than welcome to leave a comment in the question and they will be addressed. I'd like to take a moment to introduce Dr. Allison Farley, who is a research health scientist at Birmingham VA Medical Center, where she is finishing a postdoc in health services research under the mentorship of Stefan Kertesz. She is also involved with the Center of Addiction and Pain Prevention and Intervention at the University of Alabama in Birmingham. Her training is in health behavior and implementation research. Dr. Stefan Kertesz is a physician at Birmingham Veterans Affairs Medical Center and a professor of medicine at the University of Alabama at Birmingham School of Medicine. His clinical work and research have focused on care of highly vulnerable populations, including persons experiencing homelessness where pain, medical morbidity, and addiction may be present. He is board certified in internal medicine and addiction medicine. He serves on the opiate advice team and pain committees at Birmingham Veterans Affairs Medical Center. We are very grateful to Dr. Stefan Kertesz and Dr. Allison Varley for taking the time to present to us today. I turn the time over to them.
Hi, everybody. I think, Dr. Varley, you have the slide control, right? Okay. So we're delighted to be on today. We know that some people will hear this afterward because there's an inauguration going on right now. We will try to provide no malarkey today. Continue. We're going to be discussing a paper that was published last month in the Journal of General Internal Medicine, which we co-authored, and since our 2 co-authors are not on with us, we want to give them special credit. Megan McCullough at the Bedford VA and UMass, as well as Beth Darnall at Stanford University, who are also very influential in how we developed this article for a special issue in the Journal of General Internal Medicine. Next slide. And as you know, see, I'll develop the background, and then Dr. Varley is going to walk us through the implementation science aspect. So the overview for this, go back, please. The overview for this talk is we'll discuss the background in terms of how opioid prescribing has changed, the need for implementation science, consolidated framework for implementation research, which is a way to think about how we're actually making changes in real time, and metrics that would allow us to assess the implementation that are potentially more patient-centered, and then we'll have a chance for discussion. Next slide. So I think the background is one that you all know, but I do want to personalize it in a way. So there was a 20-year or more rise in widespread prescribing of opioids for long-term chronic pain. I think the data shows that these are medicines that are modestly effective on average, which means, of course, they're helpful for some, but there's no doubt that they were widely overprescribed, often as a substitute for more appropriate pain care plans for a lot of people, even though others actually need them. In that process, there was also a rise in addiction involving opioids and overdose. We can have some debate about, to what extent is that addiction related to diverted pills versus pills that were received in a doctor's office. But I did want to show the story of Ryan Hampton, who is on Twitter as Ryan for Recovery and actually supports recovery. He really describes his own story as one where he had gotten a prescription for an injury and gradually just wound up on escalating doses and gradually found those insufficient. And he really didn't understand what was going on for himself. And at a certain point, he wasn't getting enough from his point of view as a patient and wound up using heroin, which led his doctor to stop his prescription. And he realized he had a significant addiction. So while the proportion of individuals whose addiction started with the doctor versus with diverted pills is variable, I do think it's important to understand that not all of this has been good for the patients who we were supposed to be taking care of. Continue. Obviously, there's been a big change in opioid prescribing. You can see the peak was in 2011. Very often people set their sights on the idea that the prescriptions need to go back to some level it was in the past. There's no doubt that that really has happened. Depending on which year you're using here, if you used projected values for 2020 on the basis of morphine milligram equivalents per capita from a major commercial provider of data, we're now at the level of prescribing that we were in the year 2000, which is to say 20 years ago. Next slide. And that's led to a lot of declarations of success, both by the national government, by insurers, and certainly by the Department of Veterans Affairs. This is a press release from last summer. They make point that the percentage of patients who've received long-term opioids dropped by 70%. That drop partly includes tapering of people, sometimes without their consent, and also includes not starting people on long-term opioids. And let's continue. We're going to get to what that really means as we drive into implementation science. Next slide. So how do we know if you like the outcome of all these changes? You see, we can talk about the numbers, but the viewpoints really diverge, and that's Rodin's The Thinker, which means our goal is to get you to think. Next slide. There are divergent perspectives. Here, one way to talk about whether this has succeeded is to note that we now have the highest number of overdoses ever recorded in a 12-month period. Of course, the overwhelming majority of those overdoses involve an illicit opioid market. The percentage that actually involve finding a potentially prescribed opioid in the body of the decedent has actually dropped somewhat, although not a lot. But the question is that number evidence of success, or could one argue, hey, those overdoses were already booked in a sense when people acquired addiction 8 years ago, and this doesn't mean that the efforts to reduce are failing. Next slide. A converse perspective might be this. This is a kind of story that you may well have seen in the clinic and which is covered widely in the news, especially in 2019. In my other life, I have been an advocate on issues of relating to patients who have pain, who have been forced to taper off. And from their perspective, this has not been a very successful process, and they don't necessarily feel well served at all, and that's Washington Post coverage. Next slide. Experts who have written into the CDC in response to a request for commentary also reached divergent conclusions. This is a letter from a well-known advocacy organization, and it says, look, things are going pretty well. Data have shown desired downward trends in inappropriate prescribing and in prescription opioid-related morbidity and mortality. Even so, the United States continues to have much higher rates of opioid prescribing than any other developed country, and that is, by the way, true even though we're back to the levels of 20 years ago. We still have higher levels. So from that perspective, things are going well because the numbers are going down, but they're not down enough. Here's a divergent view also sent to the CDC in response to a public request for comment. Let me read it to you. Next slide. And these people write, a wide range of federal and non-federal agencies, including law enforcement and quality metric agencies, have enshrined the CDC's 90 morphine milligram threshold in ways that traumatize patients. The CDC must evaluate the use and misuse of its guideline more robustly and remediate through appropriate action. So what kind of people would actually say this? Click. Oh, it's me, Dr. A.J. Manhapra, and Dr. Adam Gordon, submitted to the public docket last summer. So, very divergent views. Next slide. Well, if we don't want to just pontificate, but actually engage in a more scholarly process of assessment, we are going to need tools that we really like to assess changes to care. And I think I speak for both Allison and I that if we could make those tools out of purple, sparkly material, that would be our preference. Unfortunately, those are probably not going to be tools equal to the task. So we're going to move forward into something that lacks the purple and lacks the sparkle, but may be more rigorous. Next slide.
So this
go ahead.
Okay, this is where implementation research comes in. And implementation research is the application of implementation science methods. And implementation science, for anyone that may have not heard of it, is the study of methods to promote the systematic uptake of evidence-based treatments and practices. And then, as I will discuss, it's also the study of methods to promote the reduction or stoppage or de-implementation of low-value treatments and practices. An important component of implementation science is the implementation strategy. And that's what we study in implementation research. It's the intervention of implementation science. It's what we do, which we'll discuss in the scope of opioid tapering, to get people to adopt the practice, or in this case, reduce or quit using a treatment or practice. So, and finally, the purpose of the commentary that we wrote for in this manuscript was to discuss other implementation outcomes relevant to opioid deprescribing. So implementations look a little different than like your traditional efficacy or effectiveness outcomes, and they evaluate the success of implementation or de-implementation. And I've provided some examples of some of the frequently used implementation outcomes like acceptability, appropriateness, which we'll discuss throughout cost and sustainability. So in our paper, we proposed that we've been a little bit narrow in thinking about implementation outcomes as far as opioid de-implementation goes. And so I'll introduce a framework that we can use to better describe opioid de-implementation context and some potential questions and metrics we could use to understand why some people are reporting that opioid prescribing is down and we're doing good, while other reports are saying that opioid prescribing is down, but patients are reporting distress and adverse outcomes due to this kind of opioid deprescribing, and that's not captured when opioid dose is the only implementation outcome. So as I kind of already introduced the implementation to a certain extent, but it's defined as the reducing or stopping of a practice that's ineffective or inappropriate, or as Prasad proposed, contradicted, unproven, or an intervention without evidence. So it's reducing or stopping some type of practice or treatment that's deemed one of these things. And de-implementation occurs at multiple levels. And when I say levels, I mean it involves physicians, organizations, and health systems. And we're about to get into one way of understanding the different levels or players involved through this framework that we'll introduce, but first a few clarifications. So we want to note that while we're interested in improving the approach to evaluating opioid de-implementation, that doesn't represent from us a commitment to eliminating opioids in practice. The purpose of this blueprint that we built is to guide the implementation efforts, evaluation efforts, in hopes of reducing adverse outcomes and healthcare inequalities. Another point we wanted to make before we jumped into the framework is that opioid de-implementation may be a little bit trickier, a little bit more nuanced than the implementation of other treatments like antibiotics, for example. And that's because opioids are helpful for some and, have a modest effect on average, which means de-implementation can mean a bunch of different things as far as opioid goes, and that could be like not starting opioids, reducing opioids, or stopping. So, as I mentioned, because there's so many levels or players involved in opioid de-implementation, we chose the Consolidated Framework for Implementation, or CFIR as I'll refer to it throughout, to guide this blueprint for evaluation that we built. And we chose this framework, as I mentioned, because it kind of displays all these multiple levels of contextual factors that influence implementation, and it combines constructs from numerous implementation theories, models, and frameworks. And understanding the implementation context can help us identify mechanisms of action, which can then help us operationalize our de-implementation outcomes. On top of the utility of this framework, there's also a lot of resources available to use this framework, and so we thought it was that's another reason why it's good to use in helping guide a de-implementation evaluation framework. There's a whole technical assistance website and an instrument repository that's currently in progress that is being developed through the Society for Implementation Research and Collaboration that maps a bunch of different measures to the different CFIR constructs. So on top of having all of those resources, there's another resource that's super helpful. And so if you use this framework to assess context for implementation, you can then identify appropriate strategies based on the barriers and facilitators that you found using ERIC, which stands for Expert Recommendations for Implementing Change. And it's a list of evidence-based implementation strategies that you can match to the CFIR constructs that you elucidate barriers and facilitators at. So this framework can help you assess context for implementation and guide your evaluation of implementation or de-implementation strategies. It consists of 5 frameworks, which we'll get into, and then in the paper, we propose metrics and questions at each of these levels that we think are important to address when you're planning for de-implementation or evaluating opioid de-implementation efforts. So the first domain of the CFIR that we discussed in the paper is characteristics of individuals. And that means what individuals are involved in implementation. It's the people in the organization, in this case, that are responsible for opioid de-implementation. Generally in this domain, we focus on the healthcare professionals involved in de-implementation, and we think that there are some additional questions that aren't potentially being asked in these de-implementation efforts that could potentially help us better understand why de-implementation is successful or not. So, here we have knowledge and competence with pain and opioids, competence in deprescribing, clinicians' distrust of patients with pain or opioid receipt, and then clinicians' motivations or perceived responsibility to treat chronic pain. So, as an example of a measure that would get at some of these constructs, specifically the desire to treat pain, I have included this example of the cat pod, which Dr. Kertesz and I discussed last year in the Journal Club, and I think Matthew might have included a link to that presentation somewhere. But we used the CFIR to create this measure, and it was heavily influenced by clinician interviews And so it's no surprise that several of these domains cover characteristics of clinicians. So, for example, we have questions about the clinician's desire to work with patients with pain and their ability to assess risk in patients. And we also have some other questions that we'll get at some of the other domains that we'll discuss across the other domains, sorry. So I should note before I move on with the other domains that we're trying to provide examples for each of these domains and some potential questions that you could ask if you were going to do this type of evaluation. I've provided, like the potential metrics that we're listing are no way inclusive of everything that you can use. At the end of the presentation, I've included some links to web resources for measurement compendiums and that CFR technical assistance website I mentioned. There's lots of potential measures you can use or adapt or create, but the resources that we provide at the end will give you a starting place to look at validated implementation measures. So I just wanted to note that we've picked a few that we think are good, but they're not necessarily all of them. So another factor we think you should take into consideration when evaluating opioid de-implementation is the characteristic of the intervention. So that would be opioids. And what I mean by this is deprescribing opioids in this case. So it's how that influences the success of de-implementation. So as we discussed earlier with the clarification, de-implementation of opioids may be appropriate for some and not others. And we're rarely seeing that in studies of opioid discontinuation, people taking into account the appropriateness of discontinuation or taper in that case. And so we think that appropriateness of the implementation is really important to pay attention to. Other things we think, we should be paying attention to is what is the advantage of reducing opioids? Are there better options available? And to what extent is that accessible to people? So is there something to replace the intervention that we're taking away? So then the next level of the framework is processes. And that refers to how the implementation was enacted. So was there a plan? To what extent was that plan executed with fidelity? To what extent is the plan being evaluated? Does the implementation team meet regularly to reflect on the de-implementation efforts? So to what extent was this a well-thought-out plan that was regularly reassessed and discussed among the implementation team, and how does that affect implementation outcomes is something we think that should be considered when studying this.
Can I weigh in for a sec? Can I just comment on that one?
Yeah.
So it's really crucial. Most of the papers that you will read from the last 3 years that describe changes in prescribing related to a policy do not describe appropriateness for the patient. They do not describe protocols other than perhaps we set up a rule or we set up a prescription drug monitoring program. These are published in high-range journals, JAMA, Lancet, almost all the major journals are publishing papers in which merely the number of people receiving pills and some generic statement that there was a plan to change them is all that they provide. And you truly have no sense of really what was done on the ground, how were the staff treated, or what was going on for the individual patients. And that's unfortunately what we're trying to say is not appropriate for studying this problem.
Yeah. Thank you, Dr. Kertesz, for adding that. So then the last domain that I will review before I hand this back over to Dr. Kertesz is the inner setting, which in my opinion is one of the more important domains and one of the domains that's relatively under-recognized in opioid de-implementation work. The inner setting consists of the organizations and factors within the organization that influence de-implementation. So, for example, we think de-implementation efforts should be reporting on things like psychological safety and the degree to which organizational leadership has committed to supporting the implementation efforts. Also, what resources were available or needed to successfully support the implementation efforts. How is the implementation team communicating about the implementation? Did clinicians have access to any specific knowledge or information or resources for de-implementation? How is the organization supporting de-implementation, and how does that influence the implementation outcome? So we think, those are some of the important questions that should be asked that aren't necessarily being asked right now. And so there's a lot of different kind of questions that this is a very large domain. It's very well developed. And there's been a lot of work to create measures to evaluate implementation context at this level. So for example, Fernandez and colleagues published this in Implementation Science. They created multiple scales to assess a bunch of different constructs in the inner setting. So I've provided a few examples here, and just wanted to note that I always, when you're starting to assess, implementation context and implementation outcomes, it's always good to start by looking at what is existing and see if you can use them and not have to go and validate your own measures. So that's why I like to provide examples of already validated measures. But if, these measures aren't sufficient, you could potentially adapt them or, to reflect opioid de-implementation or any other type of implementation effort. So you can see here, this is an example and some broad questions related to culture within the organization. And then we have another example of another measure within the inner setting, and that's leadership engagement. So how involved is the leadership in the de-implementation effort? Are they creating a supportive environment? So those are two examples of potential measures that you could use or adapt that are already created and validated for measuring this within the inner setting. And so now, Dr. Kertesz, I'm going to let you talk about what we feel is the biggest influence of success or failure of opioid de-implementation and what really needs kind of a overhaul, and that's the outer setting.
So just to be clear, the Consolidated Framework for Implementation Research provides a set of domains to evaluate. Oh, sorry. Just to be clear, the Consolidated Framework for Implementation Research provides a set of 5 domains to evaluate when considering changes to care that you are trying to execute across large organizations. And those include internal processes, the people who are doing it, the inner setting, whether the clinicians and their management talk to each other, and whether they can share their concerns or ideas about what's going on. But any form of implementation of a new health policy also is influenced by what's called outer setting, which is all of the things outside of that clinical organization, whether it's an insurer or a hospital, that are simultaneously influencing that practice. So those factors are influencing implementation from outside the organization. They routinely include external policies and incentives. For instance, is deprescribing of opioids for individual patients a mandated affair? Or to what extent is it mandated, encouraged, punished, or demanded? And who is charged with communicating the policy direction? Is it the president? Just as an example, I've shown a picture from the Atlanta Journal-Constitution where the headline was that prosecutors notified 30 doctors about excessive opioid prescribing. You might not think that those prosecutors are engaged in healthcare implementation, but they really are, because that headline draws the attention of all the people who would work in any number of healthcare organizations, and that will cause them to assess the nature of their practice within the confines of their organization differently when they understand that a federal prosecutor is interested. So they become part of that implementation chain. Of course, there's many, many parties working at once in the opioid space. Next slide. We've tried to break out how many different speakers or actors are influencing policy. Sometimes people will say policymakers and you think just of a government official, and that's why we're using this expression policy actors. when a clinician is working with a patient, whether it's in the VA or outside of the VA or in a small clinic, or whether they're a nurse practitioner in a large hospital chain, they're in some way interacting with all of these policy actors at once, some of which are dictating specific things to do, others of which are setting the framework for what they must do. There's no perfect categorization, but we've broken them into 4 categories here. Governmental actors can include the Department of Health and Human Services, documents that they issue, the Food and Drug Administration, which has educational programs, black box warnings, and the Department of Justice and the DEA, who have a formal governing role in how healthcare in this arena is carried out, including the power to imprison. The Centers for Medicare and Medicaid Services, and specifically their Medicare Part D policies, influence what can be prescribed, state laws and regs, and medical boards for the state, or nursing boards, or medical boards for physician assistants. Guidelines and metrics also influence, even though they are not necessarily binding. I've put up a few in that lower left-hand corner. In the lower right-hand corner, I've mentioned providers and payers. They could include pharmacy chains that have established rules about what they'll dispense, pharmacy benefit managers who took a strong stance that they could arrest the opioid crisis in part by determining length and dose that they would fill, hospital administration, and that would certainly be within the VA and outside of it, and even malpractice policies can tell physicians this is what we'll protect you for. And finally, in the upper right-hand corner, I want to draw attention to the language and headlines and journalists. You might not think that somebody like Vox.com's Herman Lopez is a policy actor, but when somebody influential summarizes the changing direction of healthcare, that's actually often all that we see, because we can't possibly read all the documents written by everybody else. So we get our gestalt from headlines and book covers. Next slide. Finally, the next element that is part of the, we sort of considered a subsidiary of external context, is actually the population that's coming in. Are we serving veterans? Are we serving non-veterans? Are we serving disabled people? Are we serving people who've just had surgery? So even though they're obviously customers, they're in a way coming into an organization that might be changing its care. So the needs of the patient being served is this domain, and it's part of external context, and it's the extent to which patient needs, as well as the actual barriers and facilitators to meet those needs, are known and prioritized by the organization. For instance, if a lot of your population is rural, does the organization have a plan to deal with people who could not possibly ever get to in-person services that you believe are optimum for pain care? The proposed evaluation metrics for those customers could include their satisfaction with care, their pain, and we put because we also know that there's a lot of controversy with some people suggesting that it was a mistake to emphasize and measure reports of pain in the way that it was incentivized, which in a way was a different kind of implementation failure. We can assess whether patients have access to alternative treatments, and if so, do all of them. We can assess the needs of the patients and their perception of whether prescription opioid reductions are consensual or not. That can be assessed. What is the patient's perceived autonomy in the care that is happening to them? That also can be assessed, or we cannot assess it. And finally, the patient's quality of life, and there's standardized tools for measuring quality of life. Next slide. Just to give you examples, again, I wanted to highlight that a randomized controlled trial of opioid taper has assessment tools for things like the perception of the patient's degree of choice in beginning an opioid dose reduction, their expectations of treatment, which is the second row in that, and then the third, and this is from Dr. Darnall, pain and dose expectations, which is what does the patient expect when their pain medication is changed. Next slide. The article that we published proposes a set of enhanced metrics for success in assessing prescription opioid de-implementation. That is to say, in an ideal world, if NPR, New York Times, and Wall Street Journal were to ask us, they would never have another headline that says prescription opioids went down. It would be prescription opioid change metrics indicate the following has happened. I realize it doesn't work for newspaper headlines, but this is what we really think we should consider. Every single metric we propose has some value and it has some challenges. None are perfect, but as a few examples, and admittedly the font is small. A systems level metric could be mortality after the opioid dose is changed. You can actually test whether patients are alive or dead after you've changed their prescriptions. That's not hard to find out. It's just something that's rarely measured. Whether there have been hospitalizations of patients within 3 months of an opioid dose change. Again, easy to check, never reported. The number of patients who are accessing alternative pain care in the VA, that is something that's often reported internally and sometimes reported externally. It's valuable. There are justifications for each of those, but there are challenges with each of the metrics I've mentioned. For instance, whether people are dead or not, you can't say you know for sure what caused the death. You're going to have to debate that. Whether people are hospitalized or not, you may not know the exact specific cause. All you can know is that the hospitalizations went up or down. It's an indicator, not a perfect reflection of God's truth. Let's look on the right-hand side of the same graph. You could sort of look at individual measures, and some of these we alluded to above. What are the patient's expectations of pain, and how does the change in their care relate to those expectations? Of course, the challenge is that patients' own experiences and expectations vary over time. You could look down at the very bottom, the use of other illicit drugs or alcohol in the context of opioid prescription change. We often find out that some patients have adjusted course when their prescriptions went away to using illicit substances, but we don't assess it in a standardized way. And there are a couple of barriers there, one of which is that our own laboratory tests have poor accuracy unless you're using highly accurate tests, but also we tend to use the results of that measurement in a punitive way, which actually incentivizes patients not to be disclosing with us about the changes in their usage of substances. Ideally, we would not do that, and then we would learn what's really happening for patients without that threat of punishment of them. Next slide. Take-home messages. Allison, do you want to take over?
Yeah, it's fine. So, the implementation involves reducing a practice that's been overused or doesn't have sufficient evidence or has been deemed low value. And we've seen that opioid prescriptions have fallen for 8 years, now at pre-2005 levels. There's not been careful measurement of how that was done or the effects on patients. So we argue that we must use the tools of implementation science to measure more than whether pills go up or down. So, so here in this presentation, we've pretty much just kind of given you some examples of some other types of measures and things that you can take into consideration when evaluating whether or not opioid de-implementation was successful, beyond that, kind of get more at how helpful it might have been to the patient or organization versus whether or not prescriptions went up or down.
Thank you so much, Dr. Varley and Dr. Kertesz, for that wonderful presentation. We'll now take some time and let anyone in the audience with any questions to please write them in the chat box. I do have a question right off the bat, though, if Dr. Kertesz and Dr. Varley are ready for it.
Yeah.
Excellent. Kathleen Farrell asks, often tapers are considered for safety reasons. Either the patient is not using opioids safely, or there are health concerns such as severe COPD, heart disease, or non-healing wounds that are a concern for opioids they're on. How do you suggest a provider proceed if they have these concerns and the patient does not want to taper or want the alternatives like buprenorphine?
I want to make sure we draw a distinction between the individual level and the systems level. If I'm thinking in terms of implementation science, my suggestions are going to be directed at the management of the organization where providers are addressing this question. That is, I would say, it would be ideal if management provides teams that can assist the individual clinician making those decisions. It would be ideal if the management provides and invests in access to experts who are willing either to continue or reduce opioids based on what happens to the patient. It would be ideal if the management communicates to the individual clinicians that they will not be punished based on the dose alone, but rather they will be assisted in trying to figure out what is the safest solution for that patient. There's no chance that the clinician can do a great job if they themselves do not feel psychologically safe in communicating to management what might be a very, their own personal challenges in addressing that situation, including a decision that may be to continue or to restart after tapering. if the clinician thinks that management is judging them in an adverse way unless they only do one thing, then the management has set up a psychologically unsafe environment in which the likelihood of finding out about bad outcomes is reduced. So all of those are implementation science questions, because management and the organizational leadership can actually change the conditions under which the clinician is making the decision that Dr. Farrell asks about. If we set aside implementation science and we simply ask about the clinician making individual decisions, of course, several of us have probably divergent opinions on that exact situation. I personally have been in many situations where I think the patient's safety is not optimum on the opioids that they are currently receiving. And the first thing that I start with is usually two steps. One is communication with colleagues to ask, do you think I could make the patient safer by reducing dose? And how do you think I should proceed? So I'm often asking advice, even though I'm a so-called expert. And often the other step is this communication with the patient, which says, gosh, I have a concern here, which is that your safety has been at least in question. You were admitted to the emergency room looking sedated and having also drank some alcohol at the same time as having taken the hydrocodone pills that I prescribe. And I'm now worried about your safety. And I think we can't sustain the plan that we're currently on. I want to know what you think is going on and why do you think things are where they are right now. So I actually engage people in a very frank way so that they don't think I'm anything other. I don't want to come off as a healthcare god, but more as just a fellow human being who's got to solve a problem. And I usually do mention to the patient that the safety issue has a legal sensitivity to it. I usually say something like, by the way, this decision we're making is a curiously strange one because for me, there are regulators who watch me. Just to be clear with Dr. Farrell, I have done everything you could imagine in patients who are unsafe like that. I have tapered involuntarily. I have continued but seen them every single week. I have switched to buprenorphine. I've referred to other clinicians. And, so all of those have some plausibility about them. And I don't consider myself the expert decision maker. I usually have to proceed step by step and often talk with colleagues. But the management issue is, am I safe to do that? Am I equipped with resources to make those decisions? And do I have resources to assist me when I think my plan is failing?
Thank you for that response, Dr. Kertesz. Dr. Varley, would you like to make a comment on that question as well?
No, I think Dr. Kertesz responded adequately, and I appreciate his perspective as a clinician. I am not a clinician, so I think that perspective was important to that answer.
I do see a secondary comment, which is perfectly good to read, I think, which is I have seen cases that no matter how much support we give the patient, pain psychology and other medications and treatments, and still the patient seems more committed to opioids than their safety. I think we try for the ideal, but even with all the resources stressing safety and concerns for possibly dying patients, they still want their opioids. And that's the downside of dependence, which can be that exact situation. And, there is a paper on considerations related to opioid reduction that is a consensus kind of document. I mean, it is to say, smart people argued with each other and tried to say what they think is right. If you looked at Mayo Clinic's proceedings, September, a group of people did that. It's not, by no means is it the only authoritative document, because there's more than one school of thought on this. I personally agree that there are situations where I've made decisions that did not involve the agreement of the patient. I do not, once there's a dependence factor that's part of the picture, and I think I have a very unsafe patient, it's been pretty uncommon that I actually stop opioids, because I know that were that case deemed addiction, at the very least you'd say I want them to be on the safest possible opioid rather than the one they're on. And that would probably be buprenorphine for many, even though that's not fully proven to be the ideal solution for the situation that Dr. Farrell's alluding to. But that's a clinical deliberation, and it is absolutely the case that sometimes these situations are not entirely fixable, which is like the rest of medicine, to be honest. It's just that it's really painful and anxiety-provoking here.
Thank you, Dr. Kertesz. There's a question from Ian Pace, pharmacist, who asks, so system level change is hard, takes a long time, and the dialed-in provider seeing the patient often doesn't have the time to influence. So we're left at a grassroots change at the service line level. Where do you suggest we start to try and be quote unquote better in a systematic fashion as it relates to opioid prescribing and or buprenorphine or naloxone?
And this sounds like the notion here is that the high level investment in a major systems change isn't necessarily coming, but you got to do something at the front lines, which isn't just making decisions patient by patient. First, I'm curious if Allison has any thoughts on that. Hard question.
Well, so when we were talking about kind of things in the inner setting, that may not necessarily be like leadership, but just I think getting your team on board and paying attention to some of those processes, like having a plan and having regular meetings to reflect on what's going on, and as far as kind of matching what you said the issue is to like what you could potentially do, that would be helpful. But Dr. Kertesz, you may have some other better suggestions.
I mean, we're talking now in a sense about the micro organization rather than the macro. That is, you work in a PACT, which is a patient-aligned care team, or a floor, which is a set of PACTs perhaps, and maybe there's a pharmacist there and a psychologist there. I think that in that situation, the micro setting is still influential. It is crucial for those people who are implementing the change to name what they think they are dealing with to each other. So they have to have at least a manager at the micro level say, I want to know, what we think we are doing right now. So we state what we believe we are working on. And whoever is the manager at the team level can always communicate up the ladder and say, we have assessed that we are currently working on the following problem. You may or may not have bandwidth to address it, but we want you to know we've decided that we're now dealing with a set of patients who are at high dose, and some of which are doing well and some of which are doing poorly, and we're struggling a little bit, but we're in a process ourselves. The other thing that a micro team can do is choose a low-hanging fruit thing that's not likely to be harmful. For instance, they can have literally a meeting where they commit to make sure that everybody gets naloxone, or where they have a meeting to commit to make sure that there is a debrief after anything that left any clinician feeling traumatized. We could say, if you've had an event where you felt like what was going on somehow left you feeling bad about the decisions and conversations you have, we want you to first speak with the nurse you work with. That's who I speak with. But also to let management know you debriefed on it, so we know how often that happens. You could determine at the micro level whether there is a particular resource you want to make more use of, or to request. A team could say, we would like, it could be anything from, we'd like a mental health provider stationed amongst us 1 day a week who has real interest in pain issues. It could be, we'd like to measure how many times we have called security to this floor because our opioid discussions have spun out of control, and we'd like to make that number go down. But the micro team usually depends on some lower level manager opening the door and either seeking a resource, letting people know that they want to be supportive, and encouraging direct deliberation. I think the worst situation is where individual clinicians are working behind closed doors, have things happen which they feel really uncomfortable about, and then do not have any expert or fellowship in assessing and at least naming what they're working on.
Thank you, Dr. Kertesz. Currently, we're just waiting for a few more questions to roll in. We'll see if they do. I know Dr. Gordon wanted to chime in and thank you, but I think he's having some difficulties. We'll see if he's able to join us. But I wanted to take this moment and thank you, Dr. Stefan Kertesz and Dr. Allison Farley, for your wonderful presentation. I also wanted to remind everyone to join us next Wednesday, same time, different link, but it's kind of the same place on WebEx. We'll be hearing from Dr. Ahonu and Dr. Mudra on drug overdose and suicide among veteran enrollees in the VHA, comparison among local, regional, and national data. I don't think we have any further questions.
So
Dr.
this
Stefan.
is Adam Gordon. Stefan and Allison, thank you so much for your excellent presentation today. I guess I'm going to be a provocative questioner here. So what's the future? We've certainly had a huge history of dealing with these issues over the course of the last several years. Concerns about opioid risk and assessment and mitigation. How, kind of putting the thinking caps on, where do you think the field needs to go? What do we need to see in the future to get us out of these sticky situations?
I have lots of thoughts, but I don't want to mansplain. Dr. Farley.
So I guess off the top of my head, I think increased shared decision making will be great so that both the clinician and the patient feel like they have an equal part in this process of the implementation. I think I had something else, sorry, and then I forgot. Dr. Kertesz, you can go, and I'll let you know if I remember.
Okay, feel free to interrupt. So now I'll speak a little bit more as if NPR reporters came up to me and said, what would you like to see change? What I would say is that the use of high-stakes, binary, numeric metrics to determine whether care is good or bad. For instance, the number of people on opioids or the number of people at over 90 milligrams or over 50 milligrams. These high-stakes binary metrics have been adopted in the past in other domains of healthcare without randomized trial data, and they have proven wrong, and not just in pain care, but even in diabetes, we discovered this. These metrics have to be rolled back because they dominate discussion and they narrow our focus to an extraordinary degree without having the benefit of trial data to support the notion that acting on them is safe, and yet they just tend to cone your vision down to one or two things. So I would make a strong recommendation that the people who are writing guidelines, that the people who are devising quality metrics, including the National Committee for Quality Assurance, the National Quality Forum, the Centers for Medicare and Medicaid Services, need to take another hard look at the metrics they've embraced that lacked evidence in the first place to support them as being imposed on the care of individual patients, and roll them back with the idea that you can follow something without making a hard mandate about it. I would strongly encourage a recalibration of care in which the kinds of resources that we've discussed would be added. So making sure that patients can be followed closely and that there's payment mechanisms to support the care of problems that go beyond the opioid thing, which is merely a manifestation of a complex problem that we're trying to manage. That is, the opioids were prescribed for some reason. It often wasn't the greatest reason in the first place, but somebody was reacting to often a multidimensional pain problem, which we don't track, and which we could bill for, and which we have codes to bill for, but we don't use them. So if you're going to take care of somebody who has medical, mental, trauma, and yes, opioids in their system or part of their care history, we actually need to track and bill for complex multidimensional care. There are tools to do that. We just neglect to use them, but CMS has codes for this, and we could set up systems to encourage our providers to do that. And you can actually, at least outside of the VA, you can get more pay for doing that. I would strongly think the other thing that needs to happen is it's very hard for clinicians to correct course when they have no training in the problem that they're treating. One of the things that has been so difficult, both in how we accelerated opioid prescribing and how we have reduced, is the reason we accelerated so much from 1999 to 2012 was really that clinicians came into this with almost no training in rehabilitation, no training in disability, no training in pain, and no training in addiction. And it's very easy to be manipulated by something like just a pain score and a simplistic statement about opioids being safe to get your prescribing up when you have no training in any of the background. The same thing is sort of playing out in reverse, but health profession schools could actually make a real difference here, because all of us consider problems quite a bit differently when we have training in the thing we say we're treating. If you tried to manipulate me into always prescribing the same drug for every single case of atrial fibrillation, I would not accept that, because I know that there are subtle considerations that have to be altered based on the patient, but that's because I've had a ton of training in atrial fibrillation. So I think that the training environment has to begin in the schools, but but the professional environments in which we work can actually encourage that sort of multidimensional rehabilitation framework, which then makes it easier to discuss what is in fact a very complex set of trade-offs, such as Dr. Farrell was alluding to in Dr. Farrell's questions.
And I'll just add, sorry, and I remembered what I was going to say, and I had mentioned it when we were discussing kind of all these different domains, but not only choosing better metrics for success, but better understanding context for implementation. So when we do see that there are certain organizations or units that are successfully de-implementing opioids and all of these new implementation outcomes are showing success, we can find out what are the different mechanisms of action behind that success and kind of determine what practices are really, kind of influencing success of implementation. And so paying more attention to things like psychological safety and training and leadership engagement and stuff like that to determine what it is that kind of makes the ingredients for successful opioid de-implementation. And so that you could kind of scale that up across the implementation efforts, I guess, would be the long-term goal.
So Dr. Varley, this is Adam Gordon again. I really enjoyed your de-implementation component of this. And I think that's a huge problem in our implementation science field about how to actually de-implement something. So I'm going to put another provocative, I might not agree with this question, but I'm going to make it provocative anyway. Is the de-implementation actually evidence-based in this area as well? We potentially are doing something that's not evidence-based, but can the de-implementation process be even a greater harm? Do we know what is it affect? We usually want to implement or de-implement things that are known to be correct, right? And so
so I think that's important because when we were talking about characteristics of the intervention, the strength of evidence, taper is one thing, but how you taper is another. And I know that there's protocols for a taper, and Dr. Kertesz, you may want to jump in now, but I don't know that we have an evidence-based approach to opioid de-implementation. And so, we need to learn what that is first, most likely, and then focus,
I mean, there's sort of two layers which are not evidence-based, right? Sort of, but there are, I think that this is really difficult because we're talking about two things at once. I want to remind us all, we're both speaking about the fact that for many patients with long-term opioids, deprescribing is an individual act, and the optimum way to do that, and whether it's permissible or should be permissible to do it when a patient has said no to that, is not a settled question, and that's a clinical question. I don't believe the evidence there is very clear, but the separate level is, if I have 1,000 healthcare organizations and some are going to de-implement opioids in some way that involves a management directive, and some are going to de-implement in a way that involves perhaps collaborative discussions amongst their staff with individualized work plans. Do I know which one is in fact the better way to do it? Can I prove which way is the better way to do it? No, and I certainly cannot randomize 1,000 organizations to change their practices in different ways. So I do feel that, Adam, one of the challenges is that what de-implementation science is going to wind up providing is very structured descriptions of how different groups, different organizations set about making a change, and they're not likely to have been randomized very often, and they're going to say, gosh, in a structured way, we think that what these clinics and hospitals did looks like this, given the tools available, and these other ones did it this other way, and we think the outcomes are different or not different. But it's probably never going to be a situation where you can issue a guideline that says across all healthcare organizations the way to implement change or to de-implement is always best when it's this way. All we can do is begin to offer, sort of open the door to saying that there's a thoughtful way to engage and to measure. But probably it's not going to be easy to make one gigantic generalization.
Yeah, I totally agree, and I like your analogy there. I think at least my point is that thinking about opioid risk assessment and mitigation, we've implemented it maybe to the extent that was incorrect. but there's a quandary about how do you de-implement opioid risk assessment and risk mitigation. And I'm, at least in my readings and provocatively, I can say that we don't really know what is the best way to de-implement these various heterogeneous risk assessment and mitigation strategies. Would you agree with that, or is that?
I think you're hinting at I think you're vaguely hinting at the idea that you can say we've de-implemented opioids in a general way, and we might have de-implemented wrong, and we might now need to consider de-implementing the de-implementation, like a reversal of reversals. Do I hear you right?
Yes.
Right. Like there's probably some people who've been taken off of opioids who actually probably need to go back on after very careful deliberation about what has actually happened to them, and we don't have a structure to even assess that. But if de-implementation wasn't carried out perfectly, and nothing in this world is, it's very possible that you might have to de-implement the de-implementation. And my mind is going through like a 5-dimensional space right now, and I don't have a quick way to speak to it, but the thought has dawned.
Thank you all. Matthew?
Thank you, Dr. Gordon, for your questions. Once again, thank you, Dr. Varley and Dr. Kertesz, for your wonderful presentation and your time. We also thank the audience for those who participated, both by just watching and also by commenting. We appreciate you and your input. Please join us next week for our presentation. If you need that invitation to the Fourth Wednesday link, please email me and I'll be happy to get you there. This presentation will be posted by tomorrow afternoon on our Matthew A. SharePoint. Thank you so much, everyone. Have a great day.
Thank you so much.
Thank you.